A brief overview of the management of CA testis. Very briefly, disease confined to the scrotum is stage 1. When it spreads to its first echelon lymph nodes in the retroperitoneum, the landing zones, it's stage 2. Anything beyond the retroperitoneal lymph nodes, it's stage 3. In T staging, we have to remember that the size of the testicular tumor, be it 10 centimeters or 15 centimeters or 4 centimeters, is not included in the T staging. When it is confined to the testis and the epididymis without involvement of the tunica vaginalis, that is the two layers which surround the hydrocele sac basically, it is, and without lymphovascular invasions, it is T1. Either lymphovascular invasion or involvement of tunica vaginalis makes it T2, involvement of cord makes it T3, and involvement of scrotum makes it T4. That is the reason scrotal violation should be avoided in patients with suspected testicular tumors, and it should be a high inguinal orchidectomy. The NM and tumor marker stagings are very self-explanatory. The germ cell consortium classification of the tumors into good prognosis, intermediate, and poor prognosis tumors is quite straightforward for seminoma. A seminoma of the testis with a 15 into 10 centimeter mass in the retroperitoneum, or with mediastinal lymph nodes, supraclavicular lymph nodes, or lung metastasis does not matter. All of these are good prognosis. If a patient with seminoma of testis develops a non-pulmonary visceral metastasis, for example, a liver metastasis, then it becomes an intermediate prognosis. There are no poor prognosis in patients with seminoma. Whereas in NSGCT, the presence of non-pulmonary visceral mets and very high tumor markers, along with origin of the tumor in the mediastinum, that is not testicular primary, mediastinal primary NSGCT will make it poor prognosis, and the rest are self-explanatory. It is important to remember that patients with seminoma do not have raised tumor markers, though there may be a mild elevation of HCG due to the presence of associated syncytiotrophoblastic cells. But in NSGCT, though the patient does not have distant metastasis and has disease only in the retroperitoneal lymph nodes, it may even be N1, a non-bulky lymph node. If the tumor markers are elevated to S2 range, then it makes it stage 3. So the importance of tumor markers in NSGCT should not be overlooked. So the initial imaging of choice is a CECT thorax, abdomen, and pelvis. There is no role for PET in the initial workup of patients with carcinoma of testis. Indications of cerebral imaging will be the presence of multiple lung metastasis, poor prognosis patients. All these patients, mediastinal primary, or the presence of non-pulmonary visceral metastasis, or symptoms suggestive of cerebral metastasis. All these would indicate a cerebral imaging. That testicular tumor, and after orchidectomy, roughly 4 to 5 weeks after orchidectomy. So both the values are important because the half-lives of the tumor markers are different. AFP with a 5 to 7 days, and beta HCG has a very short half-life of 1 to 3 days. Marker normalization after orchidectomy, however, does not exclude the possibility of metastatic disease. For example, a patient presented to us with a testicular tumor. The beta HCG was 7,000. We did the high inguinal orchidectomy. 4 weeks after the orchidectomy, we repeated the tumor markers. HCG became less than 1. Does not mean that the patient does not have metastatic disease. There still can be a possibility of metastatic disease. So the standard of care is high inguinal orchidectomy without testicular violation, without scrotal violation. Testis sparing surgery is a controversial area when patients with single testis develop testicular tumors or when there are bilateral tumors. It's a complex procedure involving frozen section analysis for the margins and adequacy of excision. And there are issues with local recurrence. There are issues with surveillance because the residual testis, it's very difficult to monitor if the disease is recurred in that or not. It requires a very detailed counseling, should be done in only in very select centers of expertise and not the standard of care. Contralateral biopsy of the normal testis is routine practice in some countries, but it is controversial again to recommend for all patients. It is done in some countries because there is a 10% chance of synchronous germ cell neoplasia in situ in the contralateral testis. Now let's come to the discussion of the more common and the more useful topics. So now why we did a high inguinal orchidectomy and the HPR is seminoma. This is patient A. His CT does not show any disease anywhere. Stage 1. This is patient B. His CT showed a disease in the retroperitoneal lymph node. This is stage 2. This is lung metastasis, liver metastasis, M1A lung metastasis, M1B non-pulmonary visceral metastasis. Both of them belong to stage 3. Now, how do we manage these three patients? In this patient who does not have disease on the CT, our aim is to prevent disease occurring in the retroperitoneal lymph node. 20% can have CT occult metastasis, usually in the retroperitoneal lymph nodes, because that is the first echelon spread. So if we just keep them under surveillance without doing anything, even then there is a more than 99% 5-year cancer specific survival. So whatever we do, we should not harm the patient. Initially, the surveillance protocols involved a lot of CTs, and because to avoid that, radiation was used as a means of preventing recurrence. Remember, in this patient, we are aiming at preventing the recurrence in the RPLN. There is no disease right now. So, radiation was used, but we know that testicular tumors are typically a disease of the young, and because of the young age exposure to radiation, there can be second cancers. So, RT has lost its favor for this indication. Now we use a risk adapted approach. So we have a HPR specimen of the seminoma. So though size does not matter in the T staging, a size more than 4 centimeters and involvement of the rete testis are considered as high risk factors for recurrence or relapse in patients with seminoma. Rete testis is this part of the testis. So now we have a patient with a HPR of a seminoma. We look at two factors: size, if the size is more than 4 centimeters, and if retinostasis is involved. Both the risk factors are present. We strongly recommend a single dose of carboplatin, a single cycle, because the 5-year risk of relapse based on these risk factors are as follows. With single agent carboplatin, the risk of relapse can be reduced. Now we have come to the second group of patients, that is this patient, a patient with a HPR of seminoma of the HIO specimen and who had an RPLN on the CT. Now this has to, we'll first discuss the management of non-bulky RPLN, that is N1 or N2, that is clinical stages 2A or 2B. The preferred modality in both stages is chemotherapy, 3 cycles of BEP. The alternative can be radiation. Radiation can be considered in this stage because the nodes are non-bulky and the radiation is given to the entire RPLN along with the ipsilateral iliac area. It's called a dog field RT. Now, bulky RPLN we cannot treat with radiation, and distant metastasis, lung metastasis or non-pulmonary visceral metastasis we cannot treat with radiation. So it is very simple, we just give chemotherapy. So to summarize, for this patient, we need to prevent recurrence in the RPLN. We use a risk-adapted approach. We look at size more than 4 centimeters and retinostasis involvement, and use either carboplatin or surveillance based on the number of risk factors to prevent relapse. We have a patient with disease in the RPLN but no other site of disease. In this patient, we give chemotherapy, or a less preferred alternative can be a radiation to treat the existing disease. Again, we have existing disease we have to treat, but not feasible for radiation. We give. Now, the next class of patients, we did a high inguinal orchidectomy, and the HPR is NSGCT, non-seminomatous germ cell tumors, which can be any of these types. It is very important to remember the inclusion of tumor markers in the staging of patients with NSGCT. Even if a patient had disease isolated to the retroperitoneal lymph node with N1, even it's a low volume disease, if the tumor markers are very high, S2 or S3 range, it would qualify as a stage 3 disease alongside patients with lung metastasis or non-pulmonary visceral metastasis. So very similar to seminoma, in this patient we are aiming at preventing RPLN relapse. In these patients we are treating RPLN disease or distant disease. So in seminoma stage 1, for preventing relapse, we looked at two risk factors, size and retinostasis involvement. In non-NSGCT, we look at just one risk factor in the specimen, that is the presence of LVI. If there is no LVI, patients can be kept under surveillance. And if there is a presence of LVI, or if the patients are not suitable for surveillance, then we give 1 cycle of BEP. Now, one interesting area to remember, this patient does not have disease in the RPLN. Is there any role of doing a primary RPLNT in patients with NSGCT if this HIO specimen pathology showed a teratoma with a somatic malignant component? That is, teratomas can have ectodermal, endodermal, mesodermal components, and they can have somatic malignancies like sarcomas, other carcinomas. Then we go ahead and do a primary RPLND. The other less common indication being patients with LVI should receive chemo, but they are not suitable for chemo. Then we can do a primary RPLND even in the absence of retroperitoneal disease. But while doing this primary RPLND, we have to do this extensive counseling. That after the primary RPLND, if the final pathology shows node positivity, then they'll receive 3 cycles of chemo. Even if the final pathology is completely node negative, there is still a 10% risk of systemic relapse and the complications of RPLND per se. Now, we have come to the second stage of NSGCT, disease in the RPLN. Now, unlike seminoma, here the presence or absence of tumor markers plays a very important role. Both S0 and S1 can be in stage 2. So, in the presence of elevated tumor markers, S1, we start the patient on chemotherapy, straightforward. In the absence of tumor markers, that is, this patient, S0, tumor markers are not elevated, we can do a nerve sparing RPLND, and the final histopathology of the RPLND specimen can be node negative in 20% of these patients, and they can avoid chemo. So, this 20% can avoid the chemotoxicity. 80% can have again pathological node positivity, be N1 or N2. They can be counseled for two options, either surveillance, where there is a 12 to 40% risk of recurrence, or 2 cycles of BEP, where there are some side effects but the risk of recurrence becomes very low, 0 to 4%. And bulky nodes in the RP or distant metastasis, we give chemo, very straightforward, based on the germ cell consortium risk stratification. So again, summary, we had a high inguinal orchidectomy specimen showing NSGCT. We have tumor markers with us and we have CTs with us. No disease in the retroperitoneum, tumor markers are negative. We are aiming preventing relapse in this patient in the RP. So we give a risk adapted approach. We look at LVI. If LVI, single cycle of BEP, no LVI, surveillance. In the very rare patient with a primary teratoma with somatic malignancy, primary RPLND. Now, this patient, we are aiming at treating RPLN. So, we give, we look at tumor markers S0 or S1. If S1, chemo, if S0, nerve sparing RPLND, and based on the final histopathology of the RPLN specimen, proceed. Now, we are treating distant metastasis or very high tumor markers. So, we give chemotherapy. These are brief summaries of whatever we've just discussed now. These can be useful for quick revisions. Now, the more interesting part. Now, what is the role of post chemotherapy RPLND? When do we do that and what are the indications? So, we have patients with stage 2 disease, no disease outside the RPLN. We have a patient with seminoma and a patient with NSGCT. We give chemo because they are stage 2. In seminoma, we know chemo is the preferred treatment. Less preferred alternative can be radiation, but let's forget all that. So we give chemo to both of these patients, and then we repeat a CT. In NSGCT, it is very straightforward. Any residual disease that is more than 1 centimeter on the CT post chemo, we do an RPLND. Whereas in a seminoma, if the residual disease is more than 3 centimeters on the CT, not one, more than 3 centimeters on the CT, even then we repeat a PET 8 weeks after the completion of chemo. So, this is the only role of PET in the management of CA testis. We repeat a PET 8 weeks after chemo, and PET has a very high negative predictive value for ruling out active metastatic disease based on the SEM-PET trial. That is why this 3 centimeter size criteria was taken. And in that PET, if the FDG with mass, if there's an FDG with mass more than 3 centimeters, then we do an RPLND. If the residual disease less than 3 centimeters, surveillance. Or the FDG PET does not show FDG with mass, surveillance. Or if the FDG mass is small in size, surveillance. So basically, the indications for semi RPLND in seminoma are quite stringent. We tend to avoid that, to remember this very easily, because the fat planes after a post chemo RPLND in a patients with seminoma are extremely difficult because of the extensive fibrotic nature of these tumors. The last part, the management of stage 3, that is anything beyond RPLN. So in this patient, we can see that the patient has multiple lung metastasis, which is M1A, but then this patient also has multiple liver metastasis, which will make him M1B. So now, if this patient will also have disease in the RPLN, we treat the patient with chemotherapy, just like we discussed, just like we discussed here, based on the germ cell consortium risk stratification. We start the patient on chemotherapy, and after the chemotherapy we assess for response in all the sites, and all residual disease can be tackled with surgical modalities, based on MTT discussions. For example, first we do an RPLND, look at the HPR, and then decide to go ahead with the metastatectomies in the liver, lungs, etc.